In this product QuickBit featuring the ProAxis table, Dr. Brett Babbitt, an avid longtime user of the product, discusses the benefits of the hinge table as well as how he uses it in his practice. Thanks so much for watching and enjoy.
So this technology not only makes routine 1 and 2 level fusions potentially easier and safer by, again, allowing less neural manipulation, but also allows us to extend the bed and to know that we are improving lordosis without having to put a lot of stress on our construct. And that's doubly important when we start thinking about longer constructs. Thoracolumbar constructs or upper thoracic to sacrum constructs that we see in revisions and long deformity surgeries. And again, having the ability to change the patient's positioning intraoperatively without having to break scrub, without having to readjust the patient, and without having to put stress on the construct is invaluable. So after appropriate decompression and my osteotomies, whether that be posterior osteotomies or 3-column osteotomies and placement of cages as necessary, I can then extend the bed and improve the lumbar lordosis before I cut and contour my rods. And that will, again, obviously decrease the amount of force that I've got to place on the construct while instrumenting the spine. As a result of that, I've seen significantly fewer complications from hardware failure at really a very delicate time of the operation. Just as we're closing the osteotomy, if screws start fracturing through osteoporotic bone and through pedicles, we lose control of the spine. And it's at that point that we start to see translation and increased risk of neural injury. And by placing the correction, or at least part of the correction, on the table and manipulating the entire patient with this much larger surface area, we can significantly decrease the risk of hardware cutout and loss of fixation at the osteotomy sites. Furthermore, this table is actually, I think, a little bit easier and faster to use than a standard table. I use this table for virtually every thoracic and lumbar case that I do, whether it be a simple discectomy or a long complex deformity correction. When I'm using this table for simple discectomy, I flex the bed, much like placing a patient on an old Wilson frame or an old knee chest positioner. And I can do discectomy in that position, which opens up the inner space and makes it easier to manipulate the neural elements. And then I can extend the bed back to neutral to check that I've got the decompression adequately performed. And that works even better for long, 3 or 4 level laminectomies with patients with severe central and lateral recess and foraminal stenosis. I can again place the bed in flexion, which makes it easier to enter the spinal canal safely and do my correction, and then put the patient in neutral alignment or even a bit of lordosis to be certain that as they are assuming the sort of alignment that they would actually have when they're upright and ambulating, and I can check to be certain that I have adequate decompression in that position. And then finally, I think it's imperative for all of our fusions, after we do any sort of bony resection, whether it's a simple 1 or 2 level decompression or multi-level osteotomies, to then manipulate the spine and significantly restore lordosis, which should be all of our goal, or rather, which should be the goal for all of us when we're performing a lumbar fusion. And I think the table makes it faster and safer to accomplish that, and again, puts less stress on the overall construct.